Today we will discuss the spectrum of illnesses that are collectively known as heat illness. At the end of the lecture, you will be able to define heat illness and its classification, describe the pathophysiology of heat illness, discuss the clinical features, and outline the approach to treatment. So maybe you'd like to pause the slideshow at this stage and just see if you can come up with a definition of heat illness. This definition views heat illness as a continuum of illnesses related to the body's inability to cope with heat. And this continuum includes minor illnesses such as heat edema, heat rash, heat tetany, and heat syncope, heat exhaustion, and finally heat stroke. Both heat exhaustion and heat stroke are heat illnesses characterized by systemic effects. However, the thing that distinguishes heat stroke from heat exhaustion is the absolute core temperature and the neurological features. Let's have a look at the pathophysiology of heat illness and heat stroke. Let's think about the causes of hypothermia and then its effects. So, hypothermia can be caused by increased production of heat, decreased heat loss, and other causes. Increased heat production can be due to an increased metabolic rate or toxic effects of drugs or other poisons that either uncouple phosphorylative oxidation, so uncouple anaerobic respiration, or increase the metabolic rate. Alternatively, increased heat production can be due to muscle exertion, and this is particularly so in young people with heat exhaustion. Decreased heat loss can be exogenous, purely due to a high ambient temperature. Decreased sweating, seen in older people with heat loss and dehydration, due to the effects of drugs or toxins such as anticholinergic drugs, and loss of CNS control, patients with strokes, or loss of cardiovascular reserve, again in older people with dehydration or cardiac failure exposed to a very high temperature. Other causes would include a decrease in acclimatization and decrease in behavioral response. And during heat waves, both of these play a part in the heat strokes we see in older patients. Acclimatization simply means the ability of the organism to adjust to changes in temperature, and this may be blunted in extremes of age and in patients with comorbid illnesses. The effects of hypothermia can be biochemical. With increased heat, complex molecules such as proteins, lipids, lipoproteins, polysaccharides may lose their structural integrity and therefore lose their function. And if you think about this, this would therefore affect the cell membrane, intracellular structures, enzymes, and hormones. Therefore, as expected, the effects of hypothermia can be widespread and multisystemic, and ultimately may lead to cardiovascular collapse and multi-organ failure, particularly affecting the renal, hepatic, and pulmonary systems. Heat stroke really consists of two different diagnoses: exertional heat stroke, seen in young, healthy adults, and non-exertional heat stroke. Exertional heat stroke is mostly seen in young people and brought on by excessive heat production due to severe exertion. These patients, during their severe exercise, may present with sentinel symptoms such as syncope, dizziness, muscle cramps and tetany, dehydration, and shortness of breath, or chest pain. If these symptoms are ignored, the patients often go on to develop full-blown exertional heat stroke. There are certain predisposing factors. Unfit people taking part in severe exertional sports will predispose to heat stroke. Inappropriate environmental conditions, particularly hot, humid conditions, obesity, the concomitant use of alcohol and drugs are all predisposing factors to exertional heat stroke in young people. Syncope and presyncope may be seen in patients with heat stroke, with exertional heat stroke, and they often indicate either cardiovascular collapse or severe central nervous system involvement. Classically, heat stroke, exertional heat stroke, is said to be associated with anhidrosis. However, that particular clinical feature varies from patient to patient. Non-exertional heat stroke is seen in older patients, particularly during heat waves or in environmental conditions that are particularly hot and humid. And this is because these older patients tend to be dehydrated, don't have the ability to acclimatize to hot climates, don't have the ability to adapt their behavior to the heat, such as drinking more fluids or getting out of the hot conditions, and suffer gradual dehydration and increase in core temperature until the clinical features present dramatically and overwhelmingly. These patients tend to have high hyperthermia, temperature of 41 degrees centigrade or more, anhidrosis, as I said, this may be variable, altered sensorium, cardiovascular changes, and changes to other systems such as the central nervous system, the kidney, and the lung. Patients with heat stroke often present with a wide pulse pressure, tachycardia, and tachypnea early on, but if left without treatment, this often rapidly deteriorates to loss of respiratory effort, hypotension, cardiac failure, bradycardia, hypo, and hypoxia. The CNS is often affected with alterations in consciousness, either agitation early on or coma later on. Severe heat injury to the brain can also precipitate central nervous system injury, such as strokes and seizures as well. We talked about some of the early cardiovascular effects. However, in the long run, these patients tend to have cardiovascular collapse with hypotension, bradycardia, arrhythmias, and ultimately cardiac arrest. The initial response to an increase in core temperature is an increase in respiratory rate, but this will not be sustained if the core temperature is not addressed. In addition, the loss of cellular integrity leads to pulmonary edema and also pulmonary hemorrhage. This pulmonary edema can be exacerbated due to renal complications, liver failure, heart failure, clotting problems, and ARDS. The gastrointestinal tract may present with complications such as upper and lower gastrointestinal bleeding, whereas hepatic necrosis from damage to the hepatic cells can lead to hepatic failure, hepatic encephalopathy, and coagulopathy. The musculoskeletal system can be profoundly affected, leading to damage to muscle cells, causing rhabdomyolysis, which then may lead to renal failure. The principles of treatment include early cooling, which could be passive, which usually involves increased evaporation using misting to wet the skin and fan therapy. Reduction of radiant heat by removing the patient from the hot environment, putting them in the shade, putting them in a air-conditioned environment. Or active cooling, which can be external, such as use of ice packs or immersion in ice water, and internal, with the use of cold intravenous fluids, cold nasogastric fluids, peritoneal lavage, or in severe cases, cardiac bypass. Respiratory support would be monitoring for pulmonary edema, as I said before, due to ARDS, acute kidney injury, hepatic failure, or cardiac failure. Judicious IV fluid resuscitation and careful fluid monitoring, including urinary output monitoring, ultrasound of the IVC, and invasive monitoring in critically ill patients. It's important to monitor these patients for hypoglycemia, which can be very common and devastating. In addition, we need to monitor their renal function, liver function, and clotting, and monitor and treat for hyperkalemia, a consequence of rhabdomyolysis, hypocalcemia, and hypophosphatemia. Rhabdomyolysis can lead to acute kidney injury, and we need to treat this with fluids and urinary alkalinization. Hepatic cellular injury leads to coagulopathy and hepatic failure. From that point of view, we need to monitor for hypoglycemia, DIC, pulmonary edema, and hepatic encephalopathy. Patients who present with a core temperature above 41 degrees centigrade, have been in coma for more than 2 hours, have severe pulmonary edema, delayed or prolonged hypotension for more than 2 days, lactic acidosis, acute kidney injury with hyperkalemia, or alterations of their transaminase enzymes after the first 24 hours or for the first 24 hours, all have a poor prognosis. If you have any questions, you can post them on our WhatsApp group or bring them with you to the Wednesday classes. So in summary, we talked about the spectrum of illnesses that make up heat illness, including minor heat illnesses, heat exhaustion, and most importantly, heat stroke. These topics are quite important for you as emergency physicians working in a tropical environment, and are equally important for your Part 1 exam.